Welcome, everybody, to the Gravity of Falls Evidence-Based Prevention Strategies, presented today by the Home Health Quality Improvement National Campaign. So we wanted to welcome you today. We have an excellent presentation in store for you today. Next slide, please. Next slide. In today's session, we're going to be talking about fall risk assessments, medications, risk and fall in the elderly, fall prevention interventions. We'll talk also about some fall prevention educational resources that are free, as well as questions and some closing remarks. Next slide. Today, the slides are located on HHQI. You can look under webinars. They are posted there for you to download. Any questions or comments that you would like to submit at any point in the presentation, please submit them to hhqi@wvmi.org. That's hhqi@wvmi.org. We have 4 presenters today. We want you to go ahead and put your questions in as you think about those, and we'll entertain those after the 2 speakers and then again after the following 2 speakers. But if there's a question for any of the speakers at the end, if time permits, we will also take those. So we'll go ahead and get started. Today, our first 2 speakers come from the Philadelphia area. We have Shelly James. She is the Home Care Case Manager at the Home Care Network in Radnor, Pennsylvania. Ms. James provides direct care to homebound clients, including coordination and communications with other disciplines. She participates in many committees and improvement process initiatives, as well as being a community educator. Ms. James is AACN Med-Surg certified, and with her today is Nancy Kimmons, and she is the Home Care Therapy Operations Manager at Rehab Affiliates, a division of Mainline Health in Radnor, Pennsylvania. She provides direct management of therapists and provides home health services and oversight of quality assurance. She participates in numerous committees, including safety meetings, fall oversight, and process improvement initiatives. Ms. Kimmons is a graduate of the University of Pennsylvania. Both speakers have been focused on fall prevention and design related to and was involved in a research fellowship sponsored by Blankenau Institute for Medical Research. So with that, I'm going to go ahead and turn it over to Shelly and Nancy.
Thank you, Misty. Good afternoon and welcome to our session, Validating a Multifactorial Fall Risk Assessment. Nancy and I work together for the Mainline Health System. As shocking as it sounds, we have almost 50 years of home care experience between us. In 2010, we had the opportunity to attend a research fellowship workshop sponsored by our health system, and we picked falls as a general topic to explore. When we started to design our research project, we wanted to choose an area of home health that we could work on together, impacting both nurses and therapists. At start of care to a home health episode, every client has a full assessment, and within that is a multifactorial falls risk assessment. The tool we had been using had never been validated. We set out to see, did the score we obtained on admission accurately alert us that this client was a fall risk? There are several accrediting organizations in home health care. Though driven by different processes, they have common goals to improve safety and quality in the home setting. The Joint Commission has declared reducing injuries related to falls as a national safety goal. Additionally, in the home care setting, the OASIS requires agencies to perform a falls risk assessment at admission. So really, who are we? We are a large home health care agency serving Philadelphia and also the surrounding 4 counties. We service clients with varied socioeconomic, racial, and cultural backgrounds. Our referrals come from hospitals, caregivers, physicians' offices, assisted living units, group homes, which serve as a client's primary residence. Our past activities related to falls has consisted of trending, developing risk assessments on our own, carrying out staff education, and most recently, moving to electronic falls tracking. What do we really know about falls? Our population in the home care setting is primarily geriatric, so this is a relevant topic. There is adequate research that shows falls in the older population raise healthcare costs and further debilitate this population. There have been many studies on falls and fall predictors, but primarily these have been used based on the hospital setting. We do know, according to the CDC, 1 out of every 3 adults over the age of 65 fall every year. Among older adults, falls are the major cause of both fatal and non-fatal injuries. In 2010, the direct medical cost of falls, adjusted for inflation, was $30 billion. Falls also predict quality of life and disability. 20 to 30% of those who fall suffer injuries that result in decreased mobility that limits subsequent independence. Even falls that do not relate an injury can lead to negative outcomes. In particular, experiencing a fall can increase an older person's fear of falling, an important psychological outcome correlated with future falls. Fear of falling leads older adults with and without a history of falling to limit activities, which eventually increases falls risk through functional decline, deterioration in perceived health status, and increased risk for admission to institutional care. We are charged with assessing for falls risk, and we have questions. Are the tools truly predictive? Are we consistently measuring the same way? For instance, do we each do a timed up and go the same exact way? What we learned, there has been an abundance of literature reviewing falls, addressing risk factors, depression in falls, and falls in the elderly related to medications that are prescribed. However, there is limited research looking at falls at the home and how the incidence of falls relates to risk assessed at admission. Beginning in 2010, the Outcome Assessment Information Set, or as we know it, OASIS, a tool used at admission by home health agencies in the United States, was revised by Centers for Medicare and Medicaid Services to include a question concerning assessment for risk of falls in the homebound population. Prior to this revision, little information was known to be gathered regarding the number of homebound individuals at risk for falls. The OASIS question specifies use of a multifactorial standardized assessment to determine level of risk for falls. At the time we started our project, no validated multifactorial tool existed. Several assessments were evaluated for simplicity of use, inter-rater reliability, and applicability in other settings besides the home. The TUG has been widely used by home care agencies as a valid assessment tool, but it lacks multifactorial elements. The primary purpose was to determine if the score on the multifactorial falls risk assessment accurately identifies the risk of falls in a homebound patient. In addition, we examined if any individual item had a higher correlation with the incidence of falls.
The hypothesis for our research study was that there is a positive relationship between an elevated score of combined factors and the incidence of falls occurring in the home. Our next task was to define the problem. The definition we used is shown on the slide. A fall is defined as an event resulting in a person coming to rest unintentionally on the ground or another lower level, and not as a result of a major intrinsic event such as a stroke or syncope or overwhelming hazard, which is defined as a hazard that could have resulted in a fall by the youngest, healthiest people. I'm going to talk a bit about our process. We culled the names of fallers from paper reports of falls written by clinicians during our defined time period, and we then reviewed their medical records to determine if they met our criteria, which are listed on the slide. We designed a tool to record the individual scores for all the items in the falls risk assessment for each subject, which I will show on a later slide. Our data collection process was a retrospective chart review. The researchers worked together reviewing the electronic medical record to collect the assessment scores. Since the starter care assessment was completed by a nurse in most cases, we also compared the falls risk scores with the physical therapy documentation completed about the same time to validate the scoring on the risk assessment. If we found significant discrepancies, we did not use that case. Along the way, we encountered a few barriers. One was working with paper reports. And for anyone who has worked with paper reports, I'm sure that's most of us, you understand that we spent time pawing through a drawer of dog-eared, sometimes illegible or incomplete documents with coffee spilled on them. Additionally, there were challenges in that many of the records did not meet our criteria or were missing scores for elements of the fall risk assessment, so this was a time-consuming process. One point, we started our project thinking that we could validate this tool by just looking at the scores of subjects who fell. Our researcher advisors felt strongly that we needed to include a comparative group of non-fallers. It turned out to be much more difficult to find non-fallers than fallers, since we don't collect reports on people who don't fall. We were able to find subjects from lists of active patients during our time frame, but this required more record review. Just a few more notes about some of the limitations. Because we selected cases at random, we used records documented by a number of different clinicians rather than a tightly controlled study group. We had educated our clinical staff on completing the assessment and specifically on correctly performing a timed up and go in the year before the study was done. Also, because this study was retrospective, we had to reject some records as incomplete, as we could not ask the clinicians for clarification if we had questions. The icing on the cake was that our agency changed software systems in the midst of our study so that we had limited access to the records for the time frame we used. This is our data collection tool, and it was based on the falls risk assessment. We recorded the scores for each individual variable for each subject, as well as the total score. This is a representation of the tool, the fall risk assessment tool our agency was using at the time of the study, with some descriptive information and the range of scoring for each item. So I'll take a moment to go through these for those who are not familiar with this tool. And please note that each item has a range for scoring. The level of consciousness is scored from alert to intermittent confusion. A history of falls refers to falls within the past 3 months. The ambulation elimination item ties incontinence issues to ambulatory status. The vision status has a range from normal to legally blind. The timed up and go is scored based on the number of seconds. The gait and balance section is descriptive, including the level of assistance, gait deviations, and balance issues. Orthostatic changes is self-explanatory. Medications ask for the number of certain high-risk medications involved. Predisposing diseases included CVA, vertigo, Parkinson's disease, arthritis, fractures, and amputations. And equipment issues address both the presence and appropriate use, including oxygen tubing. This tool was developed and published by CIMRO of Nebraska, which is the Medicare QIO for the state of Nebraska. The scoring system for the tool defines a score of 10 or greater as a high risk of fall. This slide lists some additional information we gathered during the review, although we did not analyze the results at this time. It was notable to us that 96% of our total subjects, both fallers and non-fallers, had therapy involved. The vast majority of the starter care assessments were done by nurses. The fact that therapy was involved in so many of these cases is reflective, we believe, of a generally high utilization of therapy in our agency, starting with the referral process, but also is reinforced by the process of completing the falls risk assessment.
The fallers and non-fallers had mean scores indicating high falls risk. Fallers scores were significantly higher than non-fallers. We looked at 100 people who fell and 25 people who did not fall under our care. The mean score for the fallers was 14.61, and the mean score for the non-fallers was 12.52. This slide shows the result of the t-test for difference of two means. The p-value is 0.035, which is less than 0.05 significance level. Therefore, we can conclude that there is a statistically significant difference between fallers and non-fallers in our study. This slide shows the result of the multiple linear regression. This analysis was provided by a biostatistician with a non-clinical background. The model should be used in actually predicting a fall. It was hard to differentiate the variables because the coefficients are all so close to 1. Therefore, it is difficult to say one variable is more predictive than another. When all the variables are combined in the model versus the total score, they all are significant as opposed to looking at each variable on its own. This slide shows the simple linear regression. When we wanted to see which variables were the strongest predictors, we used the simple linear regression. Looking at the left side of the graph, this showed us that history of falls, gait and balance, level of consciousness, and ambulation elimination were the strongest variables to independently or on their own predict a fall because they had the highest coefficient with the lowest p-value. The results suggest that the falls risk assessment as a whole is an appropriate tool that significantly predicts the likelihood of a fall. When all variables in the assessment are examined together, they possess a more predictive power than when each variable is considered on its own. However, the variables can be ranked in order of influence on the fall score by examining single variable regression, model coefficients, and p-values. From this, it was found that history of falls was the single most influential variable to the fall score, and orthostatic changes were the least influential.
So what do the numbers mean? We believe that the multifactorial fall risk assessment that we used was accurate at predicting the likelihood of falls. Some factors are more predictive than others. All were significant, but no one was significantly predictive alone. And the timed up and go was not significantly predictive on its own in our results. Our challenge in the home is that we cannot control the environment or the presence or absence of supervision. It is important to note that the fact that someone has risk factors for a fall does not mean they will fall, any more than a person with risk factors for a specific disease will definitely develop it. Our role as clinicians is to make our patients and caregivers aware of the risks, and especially to work with any factors which can be changed or reduced. We all know that many persons who are at risk do not fall, and the next presenters will be discussing interventions which are effective in preventing falls. So did we validate the tool? We believe that it's a useful and accurate tool, but we would welcome other studies of this type to validate our results. Since our study, many agencies have adopted the MAC-10 assessment, which was identified as a valid tool, although this tool also has a high sensitivity. Over-identifying individuals at risk could lead to overutilization of resources if referrals are mandated by results, such as requiring a PT referral in all cases. Under-identifying could lead to increased falls due to lack of appropriate education. Of course, there are many tools in wide use in the therapy community, some of which are listed here, but their focus is limited to balance and mobility. The greatest value of a multifactorial assessment may be the insight that it may bring to clinicians in taking a broad approach to the topic of falls. Therapists may tend to focus on mobility factors while overlooking others such as incontinence or medication, while nurses may tend to do the opposite. Using a multifactorial tool encourages all disciplines to consider many aspects of care and work collaboratively to make our patients as safe as possible. And that's the end of our presentation.
Thank you so much, Shelly and Nancy. Please do submit your questions in. If we'll turn to the next slide, we do have the reminder of where to submit your questions. And Eve Esslinger, one of the project managers and the coordinator, will be facilitating those questions.
Misty?
I hear you, Eve.
Okay, I'm sorry. We did have a question, and around slide 23, the speaker was mentioning the test that was published and developed and published. The speaker was asking who presented or published that test?
And this is Misty for Shelly and Nancy. I believe that was related to the tool that you used, and was that Nebraska QIO?
Yes,
CIMRO, Nebraska.
yes, that was a Nebraska CIMRO.
Okay, all right.
CIMRO, yes.
Okay. And for others?
I didn't hear that question.
I'm sorry. Is the tool available, is it publicly available? Can others use that tool?
Yeah, as far as I am aware, I recently tried to find it on the Nebraska CIMRO site, and I was not able to. But as far as I know, it is available for public use. And it's in use by a number of software providers for home health.
Okay, great. Thank you.
And this is Misty again. What we'll do at HHQI, we'll reach out to the Nebraska QIO and see if they can give us a link that is working, and we can post that and provide that to all the participants at a later time.
Currently as your validated tool for OASIS purposes.
Could you repeat that question? Sorry, we did not hear the full question.
Oh, I'm sorry. This was from Tammy asking, are you using the MAC-10 currently as your validated tool for OASIS purposes?
And Shelly and Nancy, you might have put us on mute in the meantime.
We're not on mute.
Oh, okay.
Can you hear me now?
We can hear you now.
Okay. The answer was that we are using the MAC-10 at this point in our agency.
You are? Okay, thank you. And I have several questions here. I'm going to keep going from Larry. Is the CDC STADI study program fall risk checklist now the standard of care for fall risk assessment?
I'm not familiar with that tool.
Okay, I didn't hear that mentioned, and I wasn't sure if I just missed something there or what. But let me go to the next question. And this person is wondering if you are willing to share your statistical models with our agencies.
Our statistical models were written in an article that we have published in Home Healthcare Nurse January 2014. I think you will find that information.
On the slide, number 25. Yep.
That information or reference is on slide 25.
Okay, great. So the person, and I'm sure other people, would be very, very interested in reading that article to follow up. So please look for that reference. And at this time, Misty, that's all the questions I have.
Okay, if you think of additional questions, please go ahead and submit those. We will come back and we can ask those for Shelly and Nancy related to assessments. I hope you found that very valuable. I do, reiterate, if you are doing work in falls, or reiterate a comment that Nancy and Shelly mentioned, make sure that you do get published and you do provide insight either in a journal that we can share in the home health industry, because we have such limited resources. And that is exactly what Shelly and Nancy did, is published in the Home Health Care Nurse Journal for us. So thank you. We'll be back with any additional questions later. And we'll go ahead and turn to the next slide. And I'm going to introduce the next two speakers. And we're very pleased, from Cleveland, Ohio, we have Joanne Weil Abenmar. She is a graduate of The Ohio State University with a bachelor's degree in occupational therapy and a master's degree in health informatics. Ms. Abenmar is the Director of Rehab at the University Hospital's Home Care Services, one of the Home Care Elite Top 500 hospital-based home health agencies. She has clinical and administrative experience in acute care hospitals, long-term care, and home health. And with her today is Chuck Lally. He is a graduate of the University of Toledo. Mr. Lally is a pharmacist at the University Hospital Home Care Service. He has extensive retail, long-term care, and hospital pharmacy experience. His function is to serve as a resource for home care patients, to referral sources, as well as the clinical staff. So with that introduction, I'd like to turn this over to Joanne and Chuck.
Greetings, everyone, and thanks for including us in this webinar. My name is Chuck Lally, and I'm here today in the hope I can provide a general review of medications and how they can influence fall risk in the elderly. As everyone here would agree, most healthcare professionals consider the patient's risk of falling as an important consideration in their overall plan of care. However, medications are often prescribed and dispensed without proper consideration of the specific risk of fall, and this can be a particularly difficult issue in the home setting. Elderly patients provide a challenging experience to healthcare providers in the home. Decreased strength and overall frailty are well-known issues to physical therapists and nurses. Changes in the liver as a person ages can reduce a patient's ability to metabolize certain medications as they age, leading to higher levels in the body than otherwise expected. Also, kidney function decreases approximately 1% per year after age 30, even in otherwise healthy individuals, also leading to issues in clearing renally metabolized or excreted medications. So as previously mentioned, governments in the U.S. and elsewhere are beginning to increase attention to falls when medications are involved. The Joint Commission requires healthcare organizations to implement and continually reevaluate a falls reduction program, which should include a medication review as part of the overall risk assessment. But where should health professionals start in evaluating medications and fall risk in the elderly? Luckily, several sources are in place on a national, regional, and even international scope. I'll discuss 3 examples at this time. The first one is used in the United States is the Beers criteria, also known as the Beers list. It's a list that was initially compiled and published by Dr. Mark Beers in 1991. There have been several revisions, with the most current in 2012. It is currently compiled by a panel of experts in geriatric care and the American Geriatric Society. Within the Beers criteria, falls and hip fractures are considered preventable adverse drug reactions. Other ADRs that the Beers list follows are anorexia, depression, constipation, confusion, urinary retention, and urinary incontinence. Therefore, the Beers criteria deals with more than just fall risk, but is a very valuable source of information for us. There are 3 broad classes of inappropriate medication use. 1, medications that are ineffective or pose an unnecessary risk and a safer alternative is available. 2, medications that need to be avoided due to specific conditions. And 3, medications that need to be used with caution. And then the Beers list breaks its recommendations down into the 2 criteria. 1, the quality of evidence. This can be listed as either high, moderate, or low, and the strength of the recommendation by the Beers criteria, and that will either be strong, weak, or insufficient. Currently in the United States, this is considered the gold standard by many practicing clinicians. On a more local note, individual states can also have their own programs. The Pennsylvania Patient Safety Advisory, which was published in 2008 by the Pennsylvania Patient Safety Authority, which is a state agency, used data from the Pennsylvania Patient Safety Reporting System. It was a state government article that was produced by the ECRI Institute and the Institute for Safe Medicine Practices. It deals with patients that are at high risk of falls, not exclusively elderly, but they do form a predominant percentage of the falls. In 2006, Pennsylvania had around 34,000 fall events reported. Roughly 4,000 of those falls had a patient taking 2 or more medications. Of these patients, 82% were only on 2 or 3 medications, and only 2% of the falls, the patients were on 6 or more medications. 5 classes of medications were found to be commonly associated with fall events and are now considered to be associated with an increased fall risk. They were anxiolytics and hypnotics, antidepressants, that one is particularly found in the elderly, neuroleptics, and opioid analgesics and antagonists. A last category is insulin and oral hypoglycemics in diabetics. Also, in an international viewpoint, if you look north to our friends in Canada, the British Columbia Falls and Injury Prevention Coalition in 2011 published an excellent risk assessment that's specific for medications and the risk of falling. It's titled Drugs and the Risk of Falling, a guidance document by Barbara Cadario, and it is a very useful source of information on focusing on the multiple drug classes, including eye drops and alcohol use, and details the mechanisms involved in increasing risk of fall or the risk of serious injury upon a fall. And the nice thing about this British Columbia source is it uses common sense methodology that any drug can increase the risk of falling or increase the seriousness of an outcome of a fall occurs. Basically, any medication that can cause drowsiness, for example, or any medication that can increase bleeding risk upon a fall. So we'll now go and explore a few specific examples of medications that may be seen in the home setting. I'll divide these into two broad categories. The first one is, like I mentioned before, medications that increase the risk of falling. Medications a lot of times that can involve drowsiness, dizziness, or fainting. For example, Ativan. We have all seen that used in the home. Current guidelines say that for the elderly, we should avoid use for agitation due to the increased risk of syncope and the cognitive impairment involved. A lot of times, patients are dosed every 8 hours when they're taking Ativan in the home, and the half-life of the medication is 12 to 14 hours. So if you put those two together, often there's a cumulative effect that can happen. It causes increased drowsiness with the patient, and then a fall can happen. The Beers criteria, the PPSA, and the BC Falls guidance document all universally accept this medication as increasing the risk of fall. Another medication, going back to the diabetics, is glyburide, otherwise known as diabeta. The elderly have an increased risk of hypoglycemia when taking this medication. The hypoglycemia can increase the risk of fall. All three sources also universally accept this medication as increasing risk of falling. And then here's one that different sources give a different review to. Alcohol, for example. Alcohol is something in the home that definitely can increase the risk of falling and is not rated, though, in the United States by the Beers criteria and the Pennsylvania reports. But in Canada, the BC Falls and Injury Prevention Coalition does list this as something that in the home can increase the risk of fall. And this is common sense due to there's changes of oversight when a patient goes to the home compared to being in a skilled nursing facility, rehab, or hospital. But still, even within inpatient population, patients can be ordered alcoholic beverages by an MD, so this can even affect patients that are in facilities. And then the second category are medications that increase the risk of injury when a fall occurs. Unfortunately, there's often less data available, but these medications do exist, and different databases do list the medications in different ways. For example, the medication warfarin. That's a well-known blood thinner used in the United States, and it can increase the risk of bleeding after a fall. Most severely, intracranial bleeds are very commonly possible even after a modest fall in the elderly. When patients go home and they're in the home setting, they often have a change in the diet, and that can affect how the medication works, and in the monitoring of the levels of this medication. It's not rated by the Beers list. It's not rated by the Pennsylvania PSRS report, but is listed by the British Columbia Falls and Injury Prevention Coalition. Aspirin is in a similar way. At higher doses, it can increase risk of bleeding after a fall. In the United States, though, we primarily look at its increased risk of GI bleeding risk. So it's not even rated for falls by the Beers criteria. However, the British Columbia Falls Guidance document does list this medication as increasing the risk of a serious outcome in a fall by increasing bleeding risk. Also, it's not listed by the Pennsylvania PPSA. Another diabetic medication, Actos, is a diabetic agency commonly used at home in the elderly. This medication actually can be looked at as causing fall risk in multiple ways. Long-term studies have shown that Actos can double the risk of a fracture upon falling. Actually, 5% of patients have been shown to suffer a severe fracture upon fall with this medication. This is seen primarily in female patients with diabetes. Now, the interesting thing is the Beers criteria looks at this medication as having a strong recommendation to avoid with a high quality of evidence in patients specifically with congestive heart failure, where CHF exacerbations can increase the risk of fall. It's directly listed in the British Columbia Falls Guidance document for increased risks of fracture upon falling, but only listed by the PPSA for risk of hypoglycemia and the attendant risk of falling as well. So different databases definitely can list the same medication in different ways. Basically, what we have to go from there is multiple, we shouldn't have all of our data coming from one source of information when being used for a fall assessment. Now, ways to reduce fall risk in the home. The main thing is, as we've been talking here, fall assessments. It's being covered by other presenters at this webinar, and it's usually a standardized form at most healthcare organizations and usually done early in the patient care process. Also, medication reconciliation upon admission to a service with a particular check for fall risk can be helpful. Contacting pharmacy service for further information when needed is extremely helpful for specific recommendations, and definitely, as we all know, we can contact a prescriber when needed to see if the appropriate therapy is being given to the patient. A last thing on this is routine medication reassessment. Policies are often already in effect in home health care organizations, but as always, it must be remembered the vast majority of people in the home do eventually get discharged from service when appropriate from a rehab or skilled nursing perspective. In conclusion, on the medication side of things, it is well known that medications can have an effect on fall risk in the home. As patients age, decreased ability to clear medications from their system can lead to increased drowsiness or unsteadiness from commonly accepted dosing, increasing risk of fall events. Once an elderly patient falls, certain medications can increase bleeding or fracture risk, which can also lead to very serious outcomes. For patients in the home, an integrated team approach is useful for assessing and identifying fall risk, especially regarding medication use. I urge pharmacy services, when available, be included in the implementation of fall risk programs and in individual patient care. Thank you very much, and I'll be turning this over to Joanne at this time.
Thank you, Chuck. So Chuck spoke on the impact of medication on falls, and I'm going to talk about some other physical interventions that can be used. There needs to be a multi-pronged approach to interventions similar to what Shelly Nancy spoke about with the assessments being a multi-pronged approach. Prong one I'll categorize as a patient or a caregiver-centered prong, and under that I want to talk about what we do here at UH Home Care. We have a shared governance model, and we have broken it up with nursing and pharmacy and intake and office operations. Every discipline is covered in that shared governance model. But one particular group, which is made up of only therapists, make up the Quality Council on Rehab, and they developed a falls toolkit, again, multi-pronged approach. Since all tools cannot be used with all patients, and there is no magic wand for an intervention that's going to work with the patient, we wanted to provide our clinical staff with a large toolkit. So the first intervention is we switched away from the information we had in our admit pack about falls prevention, and we purchased this home care safety for people receiving care in the home booklet. It's a very nice booklet. It's got a lot of white space. It's got a lot of photographs. It's set up in bullets, as you can see. It's got bullets. It's got a large font. The table of contents goes beyond simply falls. It looks at adapting the home for safety, how to get help in an emergency, and then the falls prevention section looks at home fall hazards, tips on preventing falls, your prevention plan. As you can see on the right-hand side, there's a lot of space and lines to write in. So we ask our clinicians to use a highlighter, have the patient, have the caregiver actually write on this, almost in that transitions of care model, where there's some ownership because they're your words, how you're going to prevent the fall. And many, many pages in this book have spaces. So our nurses and our therapists use this tool as part of their interventions and use this book as intervention number one. It's got a color cover so it doesn't blend in with all those white pages that you get in your admit pack. The second intervention, and we base this on reviewing incident reports. We looked at all the incident reports over about a 3-year period, and we noted so many falls occur when the patient's getting out of bed. I have to quote one of our clinicians who, when we were looking at this project, he said, there's no prosthetic for bad judgment. And if you look at the plethora of the falls, so many of them, when you look at them carefully, are just purely bad judgment. So under intervention 2, after reviewing of incident reports, our first intervention was to issue reachers to patients as needed, and we used the functional reach test and asked the OTs to perform a functional reach test to see if reaching was an issue and if just simply issuing reachers was going to alleviate that. The next process we took up was we developed 2 tools. The first tool we identified and built was a step-by-step process as to how to get out of bed. So that sounds really simple, but we actually had kind of a flow sheet as to what you do to get out of bed. And the most important things were to review the basics ahead of time to prevent a fall ahead of time. So do you need to put a bedside commode close to the bed so the patient doesn't need to ambulate to a bathroom? Ask the patient to wear non-skid socks to bed, and they all get those from the hospitals, and maybe just wearing them to bed, that way you don't need to have the patient get up, put on their shoes and socks when there might be some urgency connected to it. The third bullet was using night lights, but another great idea that one of our OTs came up with is put a glow stick, the ones you can get at Target or any dollar store, on the assisted device, and that way at night when it's dark in the home, the patient can identify where their assisted device is because there's a glow stick on it. We also talked about just-in-case pads. We would call those a depends, but we didn't want to use that terminology. And also a toileting schedule. So those would be some preventative in case, so to prevent that urgency to get out of bed to go to the restroom in the evening. But you can see through this flow chart, get out of bed, roll onto your side, swing your legs over the side of bed, push up with arms to sit, and then sit at the edge of the bed. Do those ankle pops, say the alphabet prior to standing. And this is in case there's some orthostatic hypotension. We really want to prevent that from happening. Make sure that assisted device is in the correct place, push up, stand 5 seconds, and then walk. We've also asked that the caregiver be there to assist, and we wanted to identify caregiver assist, not unlike Nancy and Shelly identified a fall. And caregiver assist is able to see and touch the patient. So we're using that, and again, this is not a good tool for every patient, but it's a great tool for some patients. The next tool we came up with was a patient agreement, and this is as good as the paper it's written on. It's not a slam dunk, but these are really good for patients that are either unrealistic or non-compliant. So here's an example. You've got a patient who you know has had a recent orthopedic surgery and needs to use a walker, and they come to the door and their walker is in the living room still. So you know right away they're not using their assistive device. Or you've got a patient that has sustained previous falls, and what we know from Nancy and Shelly, that a previous fall is a good indicator of another fall. So we go over this agreement to help patients understand that they could be weaker and you want them to get help, and then we'll check a box, getting out of bed, reaching, getting dressed, going to the bathroom, etc. And then we can check the box or fill in ourselves, and then ask them to use their assisted device or wear a brace as needed, and have it signed by the patient and a caregiver. And again, these work out really well after a fall has been sustained to prevent a subsequent fall. The third intervention, still falling under the category of patient and caregiver-centered, is we identified that we have rehab-only admissions. There really isn't a nurse that does a focused review of every medication. There are definitely nurses that review the med profile, but there's no conversation between a nurse and a patient or caregiver to discuss the purpose, when to take, and the side effects of medications. And it's not within the Practice Act nor the skill set of a therapist to do that. So our nurses that are identified for this interaction call the patient or caregiver on the phone. They discuss the med profile that has been documented in the home and make sure these questions are answered, and gives the patient a chance to answer or ask some questions of the nurse. This has turned out to be a very, very valuable tool. And then electronically, that nurse will communicate that conversation to the therapy case manager. So the final interventions really fall under clinician education or education-centered interventions. So we talked about the timed up and go and functional reach, but it's critical that the inter-rater reliability is there. So we actually produced some video vignettes of both timed up and go and functional reach, where we actually show mock patients doing a timed up and go and issues that a therapist or a nurse might come up with, and to show them what is or is not a valid timed up and go, how to do it correctly, and then there's a competency, both written and a performed competency done. We also have a journal club that we meet once a month and discuss various journal articles regarding falls. Critically, we have to do a PDCA on interventions. So in the situation that we just discussed, we reviewed the incident reports, and that was our plan. Our do were our interventions, and then our check is we have a monthly incident committee. And that incident committee, we report out the number of falls in the rolling 12 years, the severity rating for the falls, and whether they're observed or non-observed. And then we act based on that. So the natural question will be, how are you doing with that, and have you seen a decrease in falls? And that's something that's hard to assess, because are we giving more awareness to the falls and therefore getting more incident reports? So we really have a hard time really assessing right now how we're doing. So with that, I open up to questions.
Excellent, Joanne and Chuck. So if you have questions for Joanne and Chuck, please send those in to hhqi@wvmi.org, and we're going to turn it over to Eve to, again, facilitate the questions.
Yes, we have several questions. So here we go. From Tammy, how do your nurses manage medications and recommend changes in the home care setting, as our nurses have concerns that physicians might not want to make changes to the medications? And the second part of this from Tammy is that even if they might be contributing to fall risk, so even though the meds may be contributing to fall risk, they're still hesitant to make those recommendations. And she also asked if you have any specific recommendations with communicating to physicians.
Well, I'll take that question on that, and that is always a difficult issue. Currently, especially in patients that have skilled nursing within the University Hospital home care model, you know, when they're at the home, they do a medication review upon every visit with the home, and if there's any issues that come up during those reviews, it does either the nurse will directly contact the prescriber on the issue, or they'll confer with the pharmacy staff within the home infusion division at our home care organization to see if there's any recommendations that can be made, whether it be a reduction in dose or even a discontinuation in medication, and to also help strengthen the nurse's recommendation on whether this is something strongly recommended, something that's a weak recommendation, or something that there just isn't insufficient data, but it pops up when doing the medication review that there may be an issue. So within that framework then, if it's a medication that's being dispensed by our pharmacy, usually the pharmacist will make the recommendation to the physician. And physicians, as you know, can vary widely from whether they'll accept the recommendation or not, but still it needs to be documented as such that we made the recommendation. If it's a medication that our pharmacy isn't dispensing, usually the nurse will make the recommendation to the physician's office and document the same as well. Was there anything on the second part of the question that I didn't get?
No, I think you covered it. They were asking about specific communication messages, but that was really within your answer. So I think we're good. We have lots of questions here, and we're going to try to get to as many as we can.
Okay.
That was a longer one. Here we go for Joanne. Is there, and this from Lawrence, is there a standardized home falls risk assessment tool used by OTs that can help identify environmental and functional risks for falls that can be remediated?
That's a great question, thank you, and I'm an OT. So I think the timed up and go is really a great assessment for any discipline. It can be done by OT, PT, speech, nursing. The functional reach we have tended to look at for the OTs, just looking at that reaching component. But the other one, the Barthel and the other specific OT standardized assessments that we need for reassessment purposes don't really look specifically at falls risk. Okay.
Thank you. I'm going to answer one question that just came in to see if this is being recorded, and it is. I think that's the question. Then also another question asking, again, back to you, Chuck, what anti-anxiety meds are recommended if Ativan is not?
Basically, that can be a very difficult question going from patient to patient. If anti-anxiety medications are needed, as a class, what you try to do is minimize use of the benzodiazepines. So what you'll have a lot of times is whether if you're having Ativan, for example, where if the prescriber still believes that Ativan is important in the patient's therapy, a dose reduction is often the best decision to make, whether it be sometimes an elderly patient will get by on a dose of 0.25 milligrams once daily, where a younger person may need a half milligram or 1 milligram every 8 to 12 hours. So within that, pretty much within the risk of creating fall, there are no anti-anxiety medications that do not cause drowsiness. So all of them create drowsiness, so all of them can be a risk at falls. It's just going with especially the older benzodiazepines, lorazepam or Restorol, which is one that's often used for sleep, which in an adult over age 65 can sometimes still leave them groggy in the morning and at risk of a fall. Dose reduction, or even trying, for example, of a medication to help with not anxiety, but with helping with sleep. Sometimes they can go to a small dose, like a half dose of Ambien at night to help with that. But it is very difficult when a patient's being treated for anti-anxiety, because medicinally you're trying to minimize the amount of medication that will make the patient drowsy, and at the same time, obviously, especially in the home setting or in a skilled nursing facility or anything like that, you're not wanting to restrain people that are at risk of falling. That is something definitely that is not wanted or desired. So that is very difficult to give a specific question for a specific patient versus generalizations. So I apologize for seeming to dodge that question, but that's really individualized.
Okay, we have time maybe for one more question. Folks out there, I know you're sending in lots of questions. We will be sending those questions on to our speakers after the webinar and getting answers that way. But we need to continue. One more question, and the question is from Linda. Can you please clarify your policy for medication reviews with the patients of therapy-only cases? Did you say that even though a PT opens the case and there is not a nurse assigned to the patient, that you always have the patient speak to a nurse over the phone to go over the medication list?
Yes. So we have a couple of nurses that are actually based in the office that have other duties. They do telemonitoring. They have other duties here within the office. So these particular nurses are assigned to review over the phone with the caregiver or patient the med profile. Yes, so that, yes, it's not a policy, it's a best practice.
Okay, great. Thank you so much. And she also asked, do you also do this if when questions or med issues arise during the episode of care?
Oh, absolutely.
Okay.
Yeah. Now, if it happens that way, if there are med questions that happen during the episode of care, the therapist can always reach out to the physician and get an order for a nurse if more in-depth med teaching needs to happen, and that could happen at any step. So if our nurses that call the patient see that there's some extra needs, we can always get an order for a nurse for med teaching.
Okay, great. Thank you all. I'm going to turn this over to Misty, and for those of you who did not get your questions answered, please email those to hhqi@wvmi.org, and we will send those questions on. And Misty.
Thank you very much, and again, thank you to all the speakers. They were excellent presentations and a great information for everyone to think about. There are some home health quality improvement resources that are available and have been available that are free for you to utilize or pick and choose what you might want. There is a fall prevention best practice intervention package, provides leadership information, clinical information, some checklists for leaders, tools and resources, and even looking at organizational culture, which you definitely heard that from the university hospitals, as well as the two ladies from Philadelphia, and from a physician perspective and some discipline tracks. Next slide, please. And another set of resources that we highly recommend you look at is the CHAMP resources. And you can go, they have some simple steps to fall prevention, a patient tool, as well as a home fall prevention checklist for older adults. We hear a lot, people are looking for alternative languages for their population, and they do provide those in a couple different versions. They also have a CHAMP geriatric fall prevention toolkit that you're welcome to look at. It is free. And a My Falls Free plan that might tie into what Joanne talked about with having the patient sign an agreement with them. So it's probably very comparable to that. Next slide. Another excellent opportunity for you is the Visiting Nurse Association of America, or the VNAA. They have a blueprint for excellence, and we actually served on their work group in helping to design the content and the evidence-based practices. And under their patient safety module, and all of this is free, they're offering this truly as a free service for anyone to take, there is a fall risk assessment. So it provides some tools and resources, a lot of tools that were talked about on today's presentation, references and resources, as well as a training program, and ways to think about measurement and evaluation related to falls. So this is an excellent resource, and you can go in and sign up and look around. All of that is free. Next slide. Do connect with us under HHQI. We will continue to take this fall's momentum and provide some more blogs. If you've never signed up for my blog, we send out a weekly blog, so you'll be starting to see in the next few weeks some blogs related to fall prevention and some articles and resources as well. But you can connect with us in a variety of methods. And with that, we'll want to thank you all for taking time out today to join us for this very important topic that really does come down to patient outcomes and the quality of life for patients. So we hope that you gained some insight. All of the questions that were asked that we were unable to get to today, we will follow up with the speakers. And with that, we thank all of you, and especially our 4 speakers today.